Hello, I'm Nora Hanna, Chief Engagement Officer at Sun Health, and I'd like to welcome you to this episode of Coffee Connections. We created this series to help you stay connected to the latest developments in healthcare and wellness by hearing directly from experts in our own community. The Sun Health Foundation is committed to ensuring that this region has access to the most recent medical and technological advancements, and that we attract the best and the brightest practitioners for our care. The Foundation supports scholarships for healthcare workers, programs at our Center for Health and Wellbeing, and we are the exclusive philanthropic partner to Banner Boswell and Banner Del E. Webb Medical Centers. Our mission is to empower others to live longer, healthier, and more purposeful lives. So we're excited to be able to offer you this unique access to these expert resources. Thank you for joining us, and I hope you enjoy the presentation.
Thank you so much for that kind introduction. Sorry I'm late. They had me running around this morning in clinic. I told them that was supposed to be our 9:30, but they scheduled my last patient at 9:20, of course, and then I had to drive over. So apologize for that. And good to see you, Ms. Scheidt. Glad you're doing well. So as far as the PowerPoint, do I just move to the next slide here? Oh, there we go. Perfect. So again, my name's Andrew Chung. I'm an orthopedic spine surgeon, part of Banner. Really appreciate you guys all being here. Thank you, Sun Health, for the opportunity to share something that is near and dear to my heart, which is spine, how to manage spine pain, both non-surgically and surgically. So I was asked to give a little bit of an introduction about myself. So interestingly, I started out thinking I was going to be a chiropractor, and then decided that I wanted to do a little bit more than that, and so went to medical school at the Philadelphia College of Osteopathic Medicine, and then pursued an orthopedic surgery residency here in town at the Mayo Clinic, and then did 2 fellowships in spine surgery, first at the University of Southern California, combined neurosurgical orthopedic spine fellowship, and then glutton for punishment and a huge nerd, so went on to do a second fellowship at the Cedars-Sinai Hospital in advanced minimally invasive spine techniques. Originally, I thought I was going to go into academics. Plans changed, had a family, and that kind of changed my priorities a little bit, but did a lot of research. But I do still remain active in medical education. I still teach medical students. I still give lectures to the orthopedic residents at the Mayo Clinic, and still involved in some of the spine societies nationally. This is really my pride and joy here, though. This is kind of my priority. No offense to you guys, but this is what life's all about, right? So without further ado, let's talk a little bit more about spine pain and the management of spine pain. But before we get into that, we really got to discuss and understand, where does spine pain actually come from? And so when we look at the anatomy of the spine, what we call the vertebral column, really what it is a stack of building blocks called vertebrae with intervening cartilage spacers called discs. And really the purpose of the spine, or the vertebral column, is to keep us upright and to support the weight of the body. And very importantly, it protects the electrical system, or in other words, the nerves of the body as well. And getting into what we call the neuroanatomy, or basically the anatomy of the nerves, really when we look at the electrical system of the body, as you guys may or may not know, brain, spinal cord, really kind of the main power plant of the body, controls the ability to use your arms, legs, go to the bowel, go to the bathroom even. And then off of these structures, you have the individual nerves, or in other words, the electrical wires that go into your arms and legs and allow you to feel, touch, move your arms and legs. So each one of these set of nerves or electrical wires controls a different part of the upper or lower extremity, for that matter. So in general, what causes spine pain is actually not the spine itself, but actually the muscles and ligaments that kind of surround it. And they've actually studied this, and so about 80 to 90% of spine pain comes from irritation of the muscles and ligaments around the spine. And this is important because surgery, at least in its current state, can't fix this. Okay, so we're going to get into kind of how this is managed with maybe some non-surgical means. And then kind of a close second, or I guess I should say not a close second, but maybe a distant second, is kind of the arthritic conditions of the spine that can generate spine pain. But in reality, for most of us that are over the ages of 30, it's probably some combination of the two, muscle and ligament irritation plus or minus an arthritic condition that generates spine pain. And if you look here, there's a lot of anatomy when it comes to the spine. A lot of muscles and ligaments, a lot of bones, a lot of little joints. And the truth of the matter is, I don't care which mega spine nerd you talk to in the world, we have not mastered how to fix all of these issues quite yet. So there are many times when I tell patients, they come in, they've got spine pain, I tell them, listen, I don't know that I have a good surgical option for you. And I think that's important to keep in mind. We may get there one day, but we're a lot better than we were 5-10 years ago even, but we haven't fully mastered the spine yet. So what is arthritis of the spine? Well, kind of our term for it, the scientific term is degenerative disc disease. But if you've struggled with arthritis in the hip or the knee, it's pretty much the same thing. When the disc wears out, so when we look at the spine, it consists of a bunch of building blocks, and you have these intervening discs or cartilage spacers. When the disc wears out, that can lead to bulging of the discs, bone spurs, which are a hallmark of arthritis anywhere in the body, whether in the spine or in the joints for that matter. And then different than the joints of the hip or the knee, in the spine you have your nerves there, and if you have these disc bulges and bone spurs that are forming, and there's only so much room for the nerves, well, the nerves can get pinched, and we call that nerve pinching, we call that stenosis. And notice the key word here, possible. This can possibly lead to spine pain or pinched nerve pain, or in other words, sciatica. So the number one cause for sciatica is actually a pinched nerve in the low back, about 90% of the time. And the reason why I kind of qualify spine pain as possible is because if I get an x-ray of anybody here in this room, and for that matter outside of this room, or anybody walking on the street, I'm going to find something bad. And this is not something that I made up. I mean, the spine nerds that came before me, they studied this. They actually took people that had no pain, and they got x-rays and MRIs of them, both in the neck and the low back. And what they found was that even by age 20, 30% of people already had arthritic change. And by age 60, up to 90%, age 70, 100%, with up to 60% of these people over the age of 40 having severe findings. Again, no pain. So if all I did was treat an x-ray or MRI, I would literally be operating on every single person in this room. And that's not the right thing to do, right? And you guys can see that here. And unfortunately, here in the Valley, and it may be elsewhere, but here in the Valley, we don't all understand this, even on the clinical side of things. So oftentimes I get patients in my clinic that literally have very minimal back pain and come in because somebody told them that they had some sort of serious finding in their MRI. And so I would just, maybe to give you guys some peace of mind, I would just say just because your x-ray or MRI looks bad doesn't necessarily mean it's a problem that needs to be fixed surgically. That's not to say ignore it. Still follow up with somebody who's an expert, but maybe give yourself a little peace of mind. This isn't cancer. This is something that we very commonly see. And for that matter, they've done these studies. In orthopedists, I've studied all the literature in the joints as well, and they've done these studies in the shoulder, the hip, the knee, and these same studies have been replicated and found very similar results. So again, just to kind of give you guys some peace of mind there. So MRIs can be scary, but doesn't necessarily mean that something scary needs to be done, like surgery. But still follow up with an expert and discuss the results. So in summary, from the first kind of few slides here, we all get arthritis, right? If we get an X-ray and MRI of anybody, we're going to find it. It starts at age 20, but in general, it is not a dangerous condition. And in most cases, can be treated conservatively. So here's kind of an introduction to what we're going to be talking about over the next maybe 10, 15 slides, but what are some of the conservative or non-surgical management of spine pain? So there's physical therapy, yoga, or in other words, core strengthening. We'll talk about what that means. Physical activity, I'll say it over and over again, motion is lotion, weight loss, sleep hygiene. A lot of people don't know when you aren't sleeping well, that actually makes you more sensitive to pain. That being said, it's kind of one of those things where in some cases when you have a lot of pain, that can cause you to lose sleep. And then when you don't sleep, it actually makes the problem worse. So obviously that's a tough one to tough cycle to break. But bottom line, getting good sleep is very important for the management of spine pain. And then good ergonomics. We'll talk about what that means. And then there are other kind of treatment options, chiropractic, acupuncture, anti-inflammatories, massage, all kind of, adjunct therapies that may or may not be helpful for the individual. So you may have noticed in that first kind of line there, in general, no procedures, no surgery for at least 6 weeks to 3 months. Why 6 weeks to 3 months? Well, again, that's what the spine nerds have told us. They've published this data in some of the best journals, New England Journal of Medicine, JBJS. These are all kind of our big journals. Very difficult to get something published unless the data is very good. And what people found was that in the vast majority of people with neck or low back pain, or even pinched nerve pain, people are better within 6 to 12 weeks. So you could literally sit on a couch and eat Cheetos for 3 months, and you would feel better because the body has the ability to kind of take care of it. And again, I'm not making this up. It's here in our data, and if you read the studies, it's there. Now, chronic or recurrent back pain is a little bit trickier, right? So, yeah, okay, great, Dr. Chung. This is not the first time. This is years and years of back pain or recurrent leg pain or arm pain for that matter. And I would still say conservative measures have a significant role here, and it's really for the prevention, and probably most importantly here. And I think this is a difficult one for us here, particularly in the U.S., to maybe wrap our mind around is the management of pain. Meaning there may not be a quick fix, but if you put the work in on a day-to-day basis, there may be a way to manage your pain so that it at least is more tolerable. And so a common analogy I use in clinic is that, what do you do if you have a heart attack or stroke, right? Or if you're trying to prevent one, right? Well, you're not going to go, again, sit on a couch, and I hate to use the Cheetos analogy again, but you're not going to go sit on a couch and eat Cheetos all day and then buy, a carton of cigarettes and start, chain smoking and then alternating with Cheetos in the other hand, and then, drinking a liter of vodka every day, right? We're just not going to do that. You're going to eat, well, hopefully not. We're going to eat a healthy diet. We're going to maintain a healthy weight. We're going to try to be active. We're going to avoid some of these, bad social habits to, again, keep our heart and our brain as healthy as possible, to avoid these very significantly, life-altering events. And so I would argue that similarly in the low back, it's almost like if you've had an episode of back pain, you've had a back attack, you should be doing kind of similar things to manage and keep your back pain as best managed as possible and keep your back as healthy as possible. And so again, I bring you back to this list. What does that entail? Well, it entails daily core strengthening. These are all things that I don't just tell people to do, I do them myself. Physical activity, maintaining a healthy weight, sleep hygiene, good ergonomics. Let's talk about core muscles. What are they? So core muscles are the muscles that basically support the spine. They envelop the spine and they basically give the spine kind of a helping set of hands, if you will. And the simplest analogy for how core muscles can help in the arthritic spine is right here. You've got a sapling that's struggling to kind of do its job, just to stand up straight. And so you tether it to some, stakes, right, to kind of help it out. Well, if you've got an arthritic spine, and we know the job of the spine is to hold up the weight of the body, and if it's struggling to do that, well, why not give it some help, right? And that comes in the form of keeping those core muscles strong. So that's why core muscle strengthening can be so beneficial. But here's the tricky part. It's a daily thing that you have to commit to and you have to do in order to get there. And here, again, in the US, we're a McDonald's society, right? We want something then and there, right? We want that quick fix. But when it comes to chronic low back pain or chronic neck pain for that matter, it's a marathon, it's not a sprint. Oftentimes there's not a quick fix. And so you kind of have to put the work in if, again, up to you. If you really want to get out of pain or at least better manage that pain, you've got to put the work in. It's not an overnight fix. Ergonomics are important. Posture matters. When you lift, you want to lift with the legs, hold things close to you so that you're not straining your back or your neck too much. If you work at a desk, right, you want to keep that monitor above eye level. You want to keep the shoulders relaxed so that you're not doing this all day. Of course, you're going to have neck pain if you do that. And again, these are all things that I do. When I operate, I pay attention to these things. So I'm not asking you to do anything that I would not do myself. But these things matter. Even where you place things throughout the day. So if you've got I don't know, maybe some of you, work in a wood shop or, have some other hobbies and, maybe you put all the things that you normally like to access quite frequently on the bottom shelf. Well, why do that? Because then you're bending over all day to get those items. And of course, you're going to have back pain at the end of the day. So why not put those things more kind of in this region here where you're not having to bend and twist to get these or access these items. So all of these things matter. So again, let me emphasize, everybody gets arthritis. Spine pain is common. In fact, it's the number one reason for a doctor's visit internationally. But most often it's not dangerous and most often does not need surgery. And that's coming from a surgeon. I don't get paid to tell you not to have surgery, right? So really kind of keep that in mind. And again, it's a marathon, it's not a sprint. So prevention and daily management is key. Now, that being said, I know, you guys want to know about spine surgery and kind of the latest development. So we're going to get there. So there is a reason why I have a job. There are times, 10, 20% of the time where kind of the conservative care does not work, and then we have to do surgery, right? So when is spine surgery actually indicated? Well, the simplest indication or reason to consider surgery is if you've got a pinched nerve or spinal cord and you can't use your hand, you can't walk, your foot doesn't work, and that's easy, right? We got to fix that, right? That's an electrical problem and we have to address that. So there's no question that in those cases, surgery absolutely needs to happen, unless you enjoy not being able to use your foot or hand. For pain, though, that's where the tricky part comes in. When for pain is surgery indicated? Well, the most predictable improvements for pain are, with surgery, are for pain that is related to a pinched nerve, or in other words, sciatica pain, or a pinched nerve in the neck causing pain going down the arm. That is a very predictable outcome. If we're fixing that, we can almost guarantee 90, 95% plus % of the time that should get better. Plus or minus neck or back pain. So that's the gray area. Sometimes we can make that better, sometimes we can't. And again, it goes back to the complexity of the anatomy of the spine and the fact that we really haven't mastered pain generators within the spine yet. And again, this is pain that's refractory, meaning it has not responded well to 6 weeks, and I would say at least 3 months of conservative care. Also, in these kind of situations, pain management can also be a good option. So injections and things like that. A little bit more powerful of an anti-inflammatory medication. People often ask me, well, is it going to fix the arthritis? No, it's helping your body kind of cool down from whatever is inflamed, and then maybe your body will just kind of get over it with time. That's what injections can do. This is obviously what we want to avoid, right? And for me as well, I don't ever want to put somebody through a surgery, and certainly I never want to be Dr. Death, but I never want to make somebody come out the other side and feel like it never made a difference. This is what most of us nowadays want to avoid. And I'm sure each and every one of you has a friend or family member that has had spine surgery and maybe didn't get better or got worse for that matter. And the reason for that, I think, is kind of two things. One, if we look at the history of spine surgery, really spine surgery in its kind of earliest form started in the kind of early 1900s when the orthopedic surgeons performed the first spinal fusions. But if you look at kind of where modern day spine surgery began, it's really only in the last 10, kind of 12, maybe 15 years, right? Now we've got navigation, we've got a lot of our minimally invasive techniques, we've got a lot of different technologies that we just didn't have prior to the last decade, and therefore weren't able to offer as good of a result as we are able to offer today. And what you don't see here is that also during this time, our understandings of when and how and perhaps probably more importantly, when not to operate have also evolved. So our ability to create a good outcome now for the right diagnosis of spine issue is actually quite good. And I can tell you, if my rate of failed back syndrome, or if the rate of my mentor's rates of failed back syndrome was this high, meaning people had surgery and 40% of them didn't get better or got worse, I couldn't do it. I couldn't do what I do. So we are a lot better now than what our kind of old literature tells us we were, 10, 15 years ago, with our modern techniques and kind of our latest understandings of how and when to operate. So there's a reason why I love what I do, because I get to help people, assuming they've got a problem that's fixable with surgery, get out of pain. And so for the right reasons, spine surgery is highly effective. But again, I'll tell you, in general, for pain, should be considered a last resort. So let's talk about some of the new techniques, technologies, and I see a lot of people that come to clinic asking about stem cells. Let's talk about kind of what what this looks like and if there's a role for these things. And I'll just say this: new does not always mean good, and I think most of you can hopefully agree with that. So let's talk about minimally invasive spine surgery. What is it? Mean exactly? Is it just smaller surgery? So do you take a 10-inch incision and do you turn it into 8 inches, and is that minimally invasive? Some would say that it is. And the reality is, if you look at any one of our websites, my website, any other spine surgeon here in the Valley, we all are minimally invasive spine surgeons, right? We all say that, right? But are we truly performing minimally invasive spine surgery? Well, I don't know. When we look at the reason why minimally invasive spine surgery was kind of invented, it was to preserve this particular muscle, which is called the multifidus. It's the most important core muscle in your spine. And with traditional open techniques, I don't care if it's a 10-inch incision, 6-inch incision, if you're going and you're filleting the muscle off the spine, you are destroying this muscle, and by definition, you are not doing minimally invasive spine surgery. But some would argue that they are. And I would encourage them to go read, respectfully. Read and understand how minimally invasive spine surgery truly came about. But this muscle is incredibly important to protecting the spine, and by preserving this muscle, we think we can get better outcomes. In fact, we know we can get better outcomes in the short term, but we think in the long term that it's going to make a difference as well. So true minimally invasive spine surgery better preserves this muscle, which is incredibly important. So this is a traditional approach, and this is, in all respects, one of the larger surgeries that could be done using a traditional approach. But you can see it's pretty destructive, right? All that muscle has just been filleted off the bone, and not to be gross about it, but that's what's being done. And so there's a lot of collateral damage being done, right, with that approach. And unfortunately, 80% of spine surgery is still done that way. And there can't be, there has to be consequences to destroying all kind of our native anatomy, if you will. And it's not to say that traditional open surgery doesn't work, but it's a lot like dropping a nuclear bomb on the spine. And of course, you're going to take care of the problem, but there's going to be a lot lot of collateral damage as well. So is there a way to do things better and still take care of the problem? And the answer is yes, there is. And it's the minimally invasive approach to the spine. So the idea here is, rather than kind of nuking the entire spine, well, what if you could, through very small incisions and by protecting the multifidus muscle and all kind of the normal anatomic structures of the spine, still fix the problem, but without all the collateral damage? And so it's a lot more like this analogy. Rather than bombing the spine, why not just kind of snipe the area that is the real problem? I don't mean to use like war analogies, but that was the best I could do. So I apologize if that's offensive to anybody. So bottom line is what that leads to, right? So you can see the difference here, left versus right. Right side is a traditional approach. Left side is a minimally invasive approach. Those are probably 18 millimeter, 20 millimeter tubes. On the flip side, that incision on the right side is probably 5-6 inches long, and you can see the difference there, that you're not incurring as much damage to the normal anatomy of the spine. And so what we find is that when you look at our science with minimally invasive techniques done well, it leads to faster recovery, less pain, less complications following surgery, and we think, and we're starting to see it more and more now in our science, improved long-term outcomes. It makes sense, right? If you preserve the normal of the spine, should not the spine function better in the long run? This is kind of the latest iteration of minimally invasive spine surgery. It's called endoscopic spine surgery. It's actually been around since the 90s. In fact, one of the four founders is here in Phoenix, and at the time he was considered kind of a lunatic when he was coming out with this. And so what he did was like, well, hey, you guys in the US and in Phoenix are not going to listen to me. I think it's great. I'm going to take it to Asia and Europe. Anybody who's going to listen to me and learn from me. And so he took it there, and in fact, they took off with it, and they've become masters. And only in the last 10 years, I would say even less than that, 5 years, has it kind of returned to the States, and are more people starting to adopt it. But it's kind of in its early adoption phase here in the US, but definitely has been something that has been offered in Europe and Asia for a very long time. So in fact, kind of my ethnic culture is South Korean, and those guys are the masters at this right now. But the idea here is that, again, you're taking that tube-based approach and you're making it even smaller now, and you're still able to achieve the same results as an open surgery. So you can see here, here's one of my cases, and he gave me permission to share this. You can see this person, and I know you guys can't read MRIs, but basically he had 3 levels of nerve pinching, and during the surgery, I can actually see that I've completely unpinched those nerves. So those kind of white sacs that you see there on the, I don't know if you can see my mouse there, but the white sacs there, that's actually the nerves completely unpinched. And you can see that during this technique. And if you look at these people's incisions, when they come back, it's like less than a centimeter. You can barely see them. And when I was in training at the Mayo Clinic, a 3-level decompression would have been about a 3 to 5 day stay in the hospital. This person went home the next day. So I think it's a game changer, and I think absolutely minimally invasive spine surgery works, and in the right setting can be very, very beneficial. What about robotic spine surgery? A lot of hype around robotics, and in fact, we are very fortunate here to kind of have the support of our administrators, because robots aren't cheap, and also the support of Sun Health as well, and probably many of you guys, to be able to offer robotic spine care, and for that matter, other robotic surgical care to our patients. So what's the evidence for robotic spine surgery, particularly as it pertains to minimally invasive spine surgery? So here's the deal behind the robot, and this is the exact robotic system that we just recently got here at Del Webb. We're actually one of few here in the Valley that have this, so very, very privileged to be able to offer this to our patients. But the idea is with this robotic arm, first and foremost, we're increasing the precision, the accuracy of what we do. We can actually visualize what we're doing in real time using what we call stealth navigation. And that robotic arm doesn't allow us to make any errors. So as surgeons, we don't like to admit that we can make errors, but the truth is we can. And so the robot kind of takes that percentage of error out of our human hands, so that particularly when we're doing fusion type surgery and we're putting hardware into the spine, we're able to do so with 99 to almost 100% accuracy. What I think is even cooler about the robotic system that we have is really the ability to plan the surgical case based off each individual's, basically their anatomy, prior to the surgery. So we know exactly, without a shadow of a doubt, when we're going to surgery, exactly what we're going to get done, and we're going to be able to exactly execute that plan. So this is really cool to me. And then even beyond that, now with artificial intelligence, each time we do a case, and really any one of us does a case in the United States or internationally for that matter, that data goes into a centralized database, and with artificial intelligence, with each subsequent surgery, we get better and better for the next subsequent cases. So this is pretty cool stuff. And we have access to it here at Del Webb, and again, one of the few hospitals in Arizona really that does. So, the common argument amongst surgeons, spine surgeons, and amongst the biggest nerds too, is does accuracy and precision matter, right? So if you increase the accuracy and precision of what we do with a robot, does it matter? And I think most of you would say, well, that's pretty obvious, right? It should. But for us spine nerds, we want to see the data. Does it actually matter? And from all accounts, it seems to be that yes, if you're more accurate and more precise with where you place screws and hardware into the spine, it does matter, and it leads to less complications and potentially more durable surgeries, right? So the idea, what do I mean by durable? So probably many of you have heard about somebody who's had a spine surgery, or fusion particularly, and they need additional surgery down the road, right? And so hopefully with some of these more minimally invasive techniques, robotic surgery where we can accurately place these instruments, we're thinking there may be less of that. So that's our hope. This is a key concept, though, when it comes to minimally invasive spine surgery, even though it sounds so awesome, right? And this is getting back to my idea or statement that new doesn't always mean good. Just because something is minimally invasive doesn't necessarily mean it's good. So it must, at the very least, achieve the same result as an equivalent conventional technique. So meaning, if you have a surgeon that's a good traditional open surgeon and that can do it well, that's going to be a much better surgeon for you to go to than the guy who's trying the latest thing that doesn't work, right? And sometimes it's hard to differentiate between, what will work and what doesn't. But my point is that just because something is minimally invasive doesn't necessarily mean that it's the right thing to do. And this gets into, the argument, make sure your surgeon is actually trained to do spine surgery, right? There's a lot of people, unfortunately, in the US now that are taking weekend courses and trying to do some of this stuff. And just be careful about that, okay? So there's two roads to becoming a spine surgeon. It's the orthopedic route and the neurosurgical route. So just be careful of people who are not truly trained at putting implants into people's bodies, trying to do that to you. And unfortunately, this is a thing. So just be careful about that. But that aside, most importantly, for the treatment of back pain, and I'll say this, until we master the spine, which may not be in my lifetime, but surgery is oftentimes not the answer. There are many times when somebody comes in and I tell them, listen, I don't think I can get you any better with spine surgery. That being said, if it's done for the right reasons, I think it can be very effective. And also, I talked minimally invasive spine surgery up so much, sometimes it is not an option. Maybe there is a surgery that can help, but it may not be a minimally invasive spine surgery. So just kind of things to keep in mind. Now, this is kind of a hot topic, right? I'm sure there's plenty of stem cell clinics and injection clinics out here in even the Northwest Valley. I'm not aware of them all, but what's the data behind this stuff? Does it work? Does it make sense? Well, before we kind of discuss whether it works or not, we kind of have to understand what it is. So what is platelet-rich plasma, or in other words, PRP? Basically what it is, you're basically harvesting the best stuff out of your own blood, and then you're re-injecting it back into the body. And the idea there is that platelets have a wide variety of function, including healing. So if you harvest your own platelets and you put it into an area that is, struggling, arthritis, tendon issue, whatever it may be, would it not stimulate a healing response and make you feel better? That's the idea. And, the reality, so there's all these, kind of factors that are involved on a chemical level of how that occurs. But bottom line is that platelets are very much involved in the healing process. And so if you can harvest the power of the platelet and direct it to where we think it needs to go, would that not be helpful? And the short answer is, I'll get to it at a different slide, is that yes, in certain cases, it seems to be that it can be very helpful. But that's the key word, is in certain scenarios. What about stem cells? What are stem cells? Stem cells are cells that are capable of becoming a brand new cell. So they're a cell that really haven't chosen what they want to become yet. So do they want to be a muscle cell? Do they want to be a cartilage cell? Do they want to be a bone cell? Well, they have the ability to decide that. And so the idea behind stem cells is, well, if you've got bad cartilage, what if we took stem cells and injected it into that area? Could we regenerate good cartilage? That's the hope. We're not quite there yet, but that's the hope. Now, with current stem cell therapies, the reality is most of the time, people are not injecting true stem cells into you. So when we talk about stem cells, in general, we're talking about embryonic stem cells or placental stem cells. These are the ones that really have true potential to become whatever it is that they want to become. They're very expensive to get a hold of. So especially now after the FDA cracked down on many of these stem cell clinics that were doing kind of weird stuff, most stem cell clinics don't even have access to this stuff. So when we're talking stem cells in most kind of our kind of stem cell clinics nowadays, we're talking about harvesting stem cells from the individual, from either their fat tissue, blood, or from their bone marrow, usually done from the pelvic bone, kind of processing it down and then re-injecting it into the area. Again, that is the problem. The problem with this is that there's too many factors that affect the quality and the effectiveness of stem cells. And so while there's some good data with properly kind of processed stem cells, that stem cell therapy may work for kind of tendon and muscle issues in the arms and legs and feet, or even mild to moderate arthritis in the knee, we're not quite there yet in the spine. And a lot of this has to do with the various kind of factors that affect the effectiveness and the quality of the stem cells that are actually being injected. So this is very frustrating for us because I see a lot of people coming to my clinic that have had stem cell therapy, paid 15 grand for it, never got better. Right? That's very frustrating for me because, one, they should have been counseled on that, and two, it's a lot of money, right, to not have a good, effect. So the simplest kind of way to kind of describe current stem cell therapy, or even PRP therapy for that matter, is that when we're talking a medication like aspirin, right? If you get aspirin 81 that's made by CVS, that is probably going to be the same as the aspirin 81 from Walgreens or Equate, because the drug is the same, right? Just a different picture on the front. But not all PRP stem cells are the same. And this is not to pick on our nice lady here on the left side, but probably her stem cells or PRP are not as good as the one on the right, right? And so that's the challenge of stem cell therapy, right? Is that in addition to the processing of the stem cells, it also matters where you're getting the stem cells from and who you're getting it from, right? So just be careful about that. So here's the simplest way to kind of put this, okay? So would I recommend this to a family member? Listen, if you've got 15 grand laying around and you're this guy and you want to try it, go for it, right? But if 15 grand is hard money to come by, maybe think about something else, okay? At least for now. One of my mentors is a big stem cell researcher, and he actually has a stem cell lab. And he's kind of researching the applications of stem cell in the spine. And if there's one person on earth, and there's probably more people like him, but if there's one person that I know on earth that has any financial incentive to say that stem cells work in the setting of the spine, it's him, right? If he says it works, boom, he's got millions and millions of dollars, right? But he'll be the first to tell you we're not there yet. So just be careful. So in summary, everybody gets arthritis. Spine pain is common. Nobody likes to hear this in our McDonald's-based society. Prevention, daily management is key. But importantly, the body does have the capacity to some degree, or I would say to a large degree in many instances, to heal itself. For the right reasons, spine surgery can be highly effective, particularly with minimally invasive techniques. But in general, for pain, should be considered a last resort. And again, remember, it's a marathon, not a sprint. I can't harp on this enough. Prevention is key. These are all things that I do as well. I don't just tell people to do it. Thank you very much. So you're doing it. I mean, that you're the classic, I'm going to go back to that study. You're the classic person that, right here. A lot of slides. I didn't realize I had so much. You're the classic person. I mean, you would have been one of these people that was included in the study, maybe a bad-looking x-ray, but have no pain. And again, you're kind of case in point, staying active, maintaining a healthy weight, doing things that you enjoy. Those are all important things in spite of whatever your x-ray or MRI shows to kind of, keep your back pain under wraps. So I would say just keep doing what you're doing. No, I actually have not. Yeah, I have not. I don't know. Do you know what it's called? Or? Yeah, again, there's a lot of money to be made off pain. Okay, I'll just say that. But what I'll say is this. As long as it's not harmful to you and you feel that it helps, by all means. Am I aware of any data of any patch or anything like that? No. I mean, if the data for actually taking true stem cells and injecting it into the spine isn't there yet, my sense is that a patch that potentially stimulates stem cells, probably, even less so. But again, if it helps you and you're okay, paying whatever it is that you're paying, then, by all means. Yeah, I think, again, it gets back to the idea that, for the kind of non-surgical treatment of pain, you're not fixing the problem, but you're, maybe masking it. And, if that works for you, listen, some people I know get a year to 2 years off an ablation, and they just go back for another ablation, and they get another year to 2 years. If that keeps you from needing a big surgery, by all means. Intracept is a little newer. I think the jury's still out on it, but it's kind of the same deal. If it works for you and it gets you good relief, then I think it's reasonable to consider. So I don't do Intracept. It's mainly the pain management doctors, but a lot of it has to do with when it comes to chronic pain. There is a psychological aspect to it, and the company that runs Intracept, it's called Relevant. They're actually quite thoughtful about this. They want to make sure that when they pick people that are going to get their product, that it's actually going to work. So that's why they're so stringent on making sure that the people that are going to receive the procedure are going to be the most likely people to actually have a positive response. And so I don't know if that's too confusing for you, but people that are chronic pain that have psychological or psychiatric issues, they tend not to respond as well to pain management modalities. Yeah, no, absolutely. So in general, thoracic spine issues are less common. And in general, we try to avoid operating on the thoracic spine just because to address kind of similar issues that we commonly address in the low back or in the neck, in order to address those same issues in the thoracic spine, it tends to require much bigger surgeries just because of the anatomy. So we try to avoid it, but that being said, fortunately, those types of issues are less common in terms of thoracic issues that actually need surgery or respond well to spine surgery. Now, that being said, with endoscopic spine surgery, in fact, we're starting to find that we can actually address things in the thoracic spine through much less invasive approaches. But again, it has to be for the right reasons.
Well, thank you, Dr. Chung. I have one more question.
Sure, yeah.
An important one. This is a fundraising question.
Oh.
Yeah, so I'm going to talk about some of the items that we're trying to raise funds for the hospitals.
Oh, perfect.
But they gave me a wish list
Yeah.
for an MIS spine endoscopy.
Yes.
And a surgical equipment for robotic orthopedics. And I'm curious, do you need either of these? Are these things you would use? How are they important to your work?
Yeah, no, absolutely. Thanks for bringing that up. I don't like to ask for things, but I guess I will. So yeah, we're trying to, so we do some spinal endoscopy here, but there is a form of spinal endoscopy here that we're unable to provide without the appropriate technology. And the reason why that's important, as you guys have seen, hopefully, is that with some of these less invasive approaches, we can really kind of offer surgery to people in a very kind of atraumatic way and get people back on their feet quickly. And to a large degree, with this type of endoscopy that we don't have access to yet, we can actually provide surgery for people who may not be considered surgical candidates. And so for me, it's very important to try to get that here because I want to be able to offer the best of what our current kind of spine understandings and technology, are at this point to our patients here in the Northwest Valley. And in order to do that, having that type of technology is important. As far as the robotic stuff, I don't know if that relates to me, but again, it's just about being able to provide the best level of care for our patients. I think, all things considered, I trained at Mayo Clinic, USC, Cedars. That's not, to pat myself on my back, but, that wasn't that long ago. And to have access to technology that I didn't even have access to at that time, at those big institutions here at Del Webb, that's huge. And that's a large, kind of testament to, the administration here and their support of what we're doing here, Sun Health, and, their support. And again, many of your guys' support too. So, if you guys can help us along with, being able to kind of provide, the latest and what I think is the best of evidence-based spine care to our patients. And I certainly would be very appreciative of that. So thank you guys again for your support. Yeah. Nice to meet you. Okay.
Yeah, I'm going to put you in touch with my physical therapist because he is making me do all the things that he was talking about. I've had to change the way I walk, the way I sleep, all those sorts of things to deal with back pain, and it's worked. So it is a lot about lifestyles. We will have Dr. Chung's presentation and all our last Coffee Connections and our future Coffee Connections available online. So if some of that went a little bit fast and you want to go back through it, you will be able to do that. You'll be able to access all of these now and forward online. So that's one of the things we want to offer. We're doing professional recordings of this. As you know, the foundation has been doing a lot of fundraising, and we continue to raise money for the remodeling of the Women and Infant Services Center upstairs. As a matter of fact, one of our employees, his wife just gave birth there at 3 a.m. this morning, so we're very supportive of the work that's happening in the Women's Center there, and we continue to raise money for that remodeling, as well as the endoscopy center at Banner Boswell. I don't know if you came to that Coffee Connections, but they actually, I think it was at Women of Distinction, he went through all the reasons we need to expand this. We bought these amazing robots when we did the G4G campaign, which are phenomenal, and you saw some of the work up here that they're able to do with them. But they don't fit into the suites on the same floor. So patients are going upstairs, downstairs, hopefully by elevator in a gurney. But nonetheless, it's required a lot of problems. So we're financing, and Sun Health is funding the support of that expansion. So I want you to know some of the other things we're doing. We will have more Coffee Connections. We hope to continue to see a crowd like this. It may just be Dr. Chung's popularity, but a lot of it is around issues that are important to you. And so we'd like to get your feedback on those. I think there's a little form there. If there's something you want to hear about, because we are able to, through this relationship with Banner, bring speakers that are, of the subject matters that you want to know, please let us know, because we will follow your lead on that. That's what we're here for. We're doing a lot of work right now around diabetes prevention. We are actually, our Center for Health and Wellbeing, which is supported by the foundation, is out at 2 of the casinos this week. And we have 700 Native American employees signed up to participate in our prevention program. So it's a very important resource, not only for all of us, but for everyone in the community at large. And we really appreciate your support of that. And as always, we support the Banner Sun Health Alzheimer's Research Institute. Saying that is a mouthful. I'm glad I got it all out. But if you have a chance to tour that, and we have facilitated some tours, it's fascinating, and it's amazing the research they're doing. And they brought in this new doc, I think I've mentioned this to you, who is British, but they brought him in from Sweden. He's the #1 researcher in the world. And he's going to be right here on the Boswell campus doing this kind of research. And they have figured out a way that they can just test your blood to be predictive, because it's usually at least 15 years before you show any symptoms that you already have issues with Alzheimer's in your brain. So, and there's a lot that you can do to be preventative. It's not a foregone conclusion. So those are all the things that we're working on at Sun Health. We're really committed to bringing preventive care and vital longevity to everyone in the community at large, and we really appreciate your support. So please stay connected with us. We were happy to have you here today. There's still food and drinks in the back if you would like to stay, and I think Dr. Chung will be here if you have some additional questions. So thanks very much, and enjoy the rest of your day.
To learn more about Sun Health Foundation initiatives, become a donor, or attend a future Coffee Connections event live, please visit us online at sunhealthfoundation.org or call 623-471-8500. Sun Health, empowering people to live longer, healthier, and more purposeful lives.